Welcome to the deep dive. Today, we're really getting into a fascinating and honestly critical field, clinical toxicology.
That's right.
Now, toxicology generally, looks at how substances harm living things. Could be anything, medications, environmental stuff.
Sure.
But clinical toxicology, that's our focus. It's specifically about the unwanted effects of medicines in people and also, poisoning, how it happens, how we treat it.
It's quite distinct from, say, environmental toxicology, which is more about pollutants and things we encounter out there.
Exactly. So our mission today is to really, truly understand the core principles here. We're aiming for like a mastery level of this information from our source material.
And, to really grasp clinical toxicology, it helps to see the bigger picture of drug safety.
Okay.
I mean, before any drug gets to a patient, it goes through a lot of testing. Preclinical stuff, first animals, lab tests, in vitro.
Looking for danger signs early on.
Precisely. Identifying potential hazards. Then, if it looks okay, it moves into human clinical trials. Safety, effectiveness, all closely watched.
But it doesn't just stop when it's approved, right?
Absolutely not. That's where post-marketing surveillance comes in. Even after it's widely used, we keep watching.
Why is that so important?
Because some adverse effects are rare, or maybe they only show up after someone's been taking the drug for a long time or in a really large group of people. Yeah. You might miss those in the initial trials.
It's a continuous process, learning all the time.
Exactly. Monitoring, learning, adapting.
Okay, so to build that mastery, that really deep understanding, we need to start with something absolutely fundamental.
Which is?
The dose-response relationship.
Ah, yes. The cornerstone, truly.
It sounds simple, but it's crucial.
It really is. At its heart, it's about how the amount of something you're exposed to relates to the effect it has.
Okay.
And our source material points out two main ways to look at this: graded and quantal responses.
Rated first.
Okay, graded response. Think about one person, an individual. As you increase the dose of a drug, the intensity of the effect usually goes up.
Like taking more pain reliever means more pain relief.
Exactly. Up to a certain point, of course. It's about the intensity in that one person.
Got it. So what about quantal? That sounds different.
It shifts the focus. Instead of one person's response intensity, we look at a whole population, a group.
Okay.
And we ask, what percentage of that group shows a specific, defined response at a given dose? It's more like, did they respond or not? All or nothing for each individual within that group.
Right, like, did the blood pressure drop below a certain level, yes or no?
Precisely. And this quantal approach brings us to some really important concepts. Key parameters.
Like the LD50, I feel like that one comes up a lot.
It does. The LD50 median lethal dose, it's a dose that kills 50% of a test population.
Usually animals, right?
Typically determined in animal models, yes. Now, figure 9.1a in our source makes a really critical point here.
Which is?
You can have two different compounds, X and Y, in the figure with the exact same LD50 value.
Okay.
But their dose-response curves can have totally different slopes.
And what does that mean practically?
It means that even though they kill 50% at the same dose, at lower doses, one compound might be way more toxic than the other.
I see. So the LD50 is just one point on the graph. It doesn't capture the whole picture of toxicity across the dose range.
Exactly. It tells you the midpoint for lethality, but not the risk at sublethal doses. Very important nuance.
Okay, so LD50 for lethality, then there's the ED50.
Right, the median effective dose. That's the dose where 50% of the population gets the desired therapeutic benefit.
The effect we want.
Yes. And then for safety, particularly when we're thinking about humans, we often talk about the TD50.
Toxic dose.
Median toxic dose, the dose that causes a specific toxic effect in 50% of the population.
So we've got effective, toxic, and lethal doses, all looking at that 50% mark in a population.
Correct. And these values let us calculate something called the therapeutic index, or TI.
Which tells us about safety.
It's a measure of relative drug safety, yeah. Kind of a rough guide. For animal studies, you calculate it as LD50 divided by ED50.
Okay.
For human studies, where we obviously don't measure LD50, we use TD50 divided by ED50. Equations 9.1a and 9.1b in the source show these formulas.
So a higher TI means safer.
Generally, yes. A higher TI suggests a wider gap, a bigger window, between the dose that works and the dose that causes toxicity.
And this varies a lot between drugs.
Hugely. Our source points this out clearly. Some drugs, like digoxin or many cancer chemotherapies, have a really narrow TI. maybe just 1 or 2.
Wow, that's a tiny margin for error.
It is. That's why those drugs need super careful dosing, often monitoring drug levels in the blood to make sure you're in the effective zone, but not the toxic one.
And on the other end?
You have drugs like penicillin. Assuming no allergy, its TI can be over 100. Much, much wider safety margin.
Okay, but you said the TI is a rough guide. What are the limitations? We're aiming for mastery here.
Good point. The limitation comes back to those median doses, the 50% points. The TI doesn't account for the variability in how individuals respond.
So some people might get toxic effects at lower doses than the TD50.
Exactly. And crucially, it doesn't capture the slopes of those dose-response curves we talked about.
Ah, back to the slopes again.
Yes. Look at figure 9:1 again. Even with a decent TI based on median values, the curves can overlap. Meaning, the high end of the effective dose range for some people might overlap with the low end of the toxic dose range for others, or even the lethal range.
So the TI based on the 50% points might look okay, but there's still risk for some individuals at the edges of the response distribution.
Precisely. It's a useful starting point, but it doesn't give you the full safety profile.
Which is why our source brings up the margin of safety, right, as an alternative.
Exactly. It's a more conservative way to look at safety because it considers the extremes, not just the middle.
How does it work?
Instead of comparing the ED50 and TD50, the margin of safety compares the ED99.
The dose effective in 99% of people.
Right, to the LD1 in animals or the TD1 in humans.
The dose lethal or toxic in only 1% of the population, so the most sensitive end?
Correct. The calculation is LD1 divided by ED99, or TD1 divided by ED99, shown in equation 9:2. Figure 9:1b highlights this, that cross-hatched area between the ED99 and LD1 gives a visual sense of this margin.
It feels much more cautious, focusing on protecting the most sensitive individuals.
It is. It directly addresses that potential overlap issue that the simple TI might mask.
Okay, that clarifies the limitations of TI and the value of the margin of safety. But then things get even more complicated, don't they, with these non-monotonic dose-response curves?
Ah, yes. Just when you think you've got the standard S-shaped curve figured out.
Nature throws a curveball. Or a U-turn.
Exactly. These non-monotonic curves don't follow that nice, predictable sigmoidal shape. Our source highlights 3 main types we really need to understand.
First one, U-shaped.
Yes, the U-shaped curve. You see this often with things like endocrine disruptors, hormones, essential metals, vitamins. Figure 9:2a shows it.
So U-shaped means bad at low doses, okay in the middle, bad again at high doses.
That's the idea. Very low doses, or deficiency, can cause adverse effects. Then, as the dose increases, you hit a sort of sweet spot, a range of homeostasis where things are fine.
The bottom of the U.
Right. But if you keep increasing the dose past that optimal range, toxicity reappears due to excess. Too little is bad, too much is bad.
Makes sense for essential nutrients or hormones where balance is key.
Precisely. The second type is the hockey stick curve. Figure 9:b.
Looks like. Nothing happens, then suddenly it shoots up.
Pretty much. At low doses, there's essentially no measurable adverse response. The body's dealing with it.
Okay.
But then you reach a certain threshold dose where the exposure overwhelms the body's natural protective or detoxification mechanisms.
And then you see the toxic effect kick in sharply.
Exactly. A dramatic increase in adverse effects. Formaldehyde is a good example given.
Formaldehyde, like from building materials?
Well, yes, but it's also produced naturally in our bodies as a metabolic byproduct.
Really?
Yes. And normally we detoxify it very efficiently using an enzyme called alcohol dehydrogenase.
Yeah.
But if external exposure gets too high, or our internal production spikes, it can saturate that enzyme.
Overwhelm the system.
Right.
Yeah.
Once that detoxification pathway is saturated, the adverse effects start showing up. It's like our defenses have a capacity limit.
Got it. So handleable up to a point, then boom. What's the third type? Inverted U.
Inverted U-shaped curve, shown in figure 9:2c. So the effect increases with dose up to a point, but then at even higher doses, the effect actually starts to decrease.
That seems counterintuitive. Why would a higher dose cause less effect?
Several possible reasons. One is receptor downregulation or desensitization.
Meaning the cells get tired of being stimulated.
Sort of. If a receptor is constantly bombarded by high concentrations of a drug, the cell might pull some receptors off the surface or make the remaining ones less responsive.
Yeah.
So more drug doesn't equal more effect. It might even equal less. Another possibility is that at really high supermaximal concentrations, the drug starts hitting other targets or triggering negative feedback loops that counteract the primary effect.
Reducing the overall observed outcome.
Exactly. Our source mentions cannabidiol, CBD, as an example. Studies suggest intermediate doses might be best for anxiety relief, while very low or very high doses are less effective. Estrogen can also show this pattern.
And these are common in complex systems.
Yes, particularly where a molecule interacts with multiple receptors or pathways. Things get complicated.
These non-monotonic curves really drive home the point that toxicology isn't always simple, is it? You can't just assume more dose equals more effect or more harm.
Absolutely not. It underscores why comprehensive dose-response studies, looking across a very wide range of concentrations and also looking at effects over time, are so crucial for any potential toxicant.
You really need to map out the whole landscape.
You do. Because the effect at a low dose might be totally different, qualitatively different even, from the effect at a high dose.
Okay, that lays a strong foundation on dose response. Now let's shift to what happens inside the body, especially when things go wrong. Toxicokinetics.
Right, toxicokinetics is basically pharmacokinetics ADME. Absorption, distribution, metabolism, excretion, but under toxic conditions.
So when there's way more drug than usual, like in an overdose.
Exactly. Super therapeutic quantities. And an important point our source makes is that a lot of what we know about human toxicokinetics comes from case reports, observational studies.
Because you can't ethically give people toxic doses on purpose for research.
Precisely. So we learn a lot from real-world overdose situations.
Okay, starting with A, absorption. How does that change in an overdose?
One key thing clinically is the time it takes to reach the peak drug concentration in the blood.
Why is that so important?
Because it helps determine how long you need to observe a patient. If someone took an overdose but isn't showing symptoms yet, knowing how long it might take for the drug to peak helps decide how long to monitor them before saying they're okay.
And the drug's formulation matters here, right? Like extended release.
Big time. Modified release formulations, sustained, controlled, extended release, they're designed to release the drug slowly.
So, in an overdose,
That slow release means it can take much, much longer to reach peak concentration and therefore longer for toxic symptoms to appear.
the danger might be delayed.
Exactly. You can't assume the effects will be immediate just because a large quantity was taken.
And it's not just the pill itself. The body's response can also change absorption.
Yes, delayed gastric emptying is a big one.
The stomach slows down.
Right. Certain drugs themselves can slow down the muscles in the GI tract. Opioids and anticholinergic drugs are classic examples mentioned in our source. They slow the movement of stuff from the stomach into the small intestine.
Where most absorption happens.
Correct. But it's not just those classes. A study mentioned actually found delays with tricyclic antidepressants, opioid acetaminophen combos, even acetaminophen alone, and carbamazepine.
So quite a few common drugs can slow things down in overdose.
Yes. And sometimes just the sheer volume of pills ingested can physically slow down dissolution and absorption.
Makes sense. More stuff to process. Then there's that weird Bactrian pharmacokinetics double hump.
Yeah, it's fascinating. Figure 9-3 shows it for acetaminophen overdose.
What happens?
In some really large acetaminophen overdoses, like 30 to 100 grams, you can see two distinct peaks in the blood concentration, separated by hours, sometimes 12 to 42 hours apart.
Why?
The exact reasons aren't perfectly clear, but it seems to happen with huge doses alone, or when taken with other drugs that slow gastric emptying. It just highlights how complex and unpredictable absorption can become in overdose.
Definitely not straightforward. Okay, another process affecting drug levels.
Right.
Enterohepatic cycling. Sounds like a loop.
It is a recirculation loop for some drugs and their metabolites. Here's how it works. A drug gets metabolized in the liver, often by conjugation attaching it to something like glucuronic acid or sulfate to make it more water-soluble.
To help excrete it.
Right, into the bile, which goes into the intestine. But these conjugates are often too polar to get reabsorbed easily from the intestine back into the blood. But the bacteria living in our gut, our microbiome, have enzymes. And these enzymes can often snip off that conjugate tag.
Undoing the liver's work.
In a way, yes. It deconjugates the metabolite, often making it more lipid-soluble again, and lipid-soluble molecules can be reabsorbed across the intestinal wall.
Back into the bloodstream.
Back into the portal vein, which goes straight back to the liver, and the cycle can potentially start again.
Wow. So liver prepares it for exit, gut bacteria send it back in. Our source mentions liver enzymes like CYPs and UGTs, and transporter proteins are involved too.
Yes, it's a complex interplay of enzymes and transporters in the liver and gut.
And what's the consequence of this cycling?
It can cause secondary peaks in the drug concentration profile later on. And importantly, it can significantly prolong the drug's elimination half-life. It sticks around longer.
But can we intervene, like break the cycle in an overdose?
Yes, we can. That's where things like activated charcoal come in again.
How does charcoal help here?
If you give activated charcoal orally, it stays in the gut and can bind to the drug or metabolite that gets excreted into the bile.
Trapping it.
Exactly. It absorbs it, prevents it from being reabsorbed after deconjugation, and forces it out in the feces. You interrupt the cycle.
Smart. Any other examples of binding agents?
Our source mentions bile acid sequestrants like cholestyramine, which bind bile acids, and also polyethyl resins used for dimethylmercury poisoning. It's the same principle. Bind it in the gut, prevent reabsorption, enhance excretion.
And this isn't just for drugs, right? Natural body substances too.
Correct. Things like thyroxine, thyroid hormones, steroid hormones, bilirubin. They also undergo enterohepatic recirculation. It's a normal physiological process for some molecules.
Interesting. Okay. Besides cycling, any other miscellaneous factors affecting absorption? Pharmacophores, what are those?
They're basically solid masses, like clumps, of undigested or partially digested drug material that can form in the GI tract, usually the stomach.
Like a hairball but made of pills.
Kind of, yeah. And they can mess with absorption. They might block the passage of the drug, reduce the surface area for absorption, or act like a slow-release reservoir, leaching drug out over a long time.
Leading to prolonged or erratic absorption.
Right. Though our source does say they're actually pretty rare in acute overdose situations.
Okay, good to know. What about pylorospasm?
That's when the pyloric sphincter, the valve between the stomach and the small intestine spasms shut.
So stuff can't leave the stomach easily.
Exactly. It impedes gastric emptying into the duodenum, where most drug absorption happens. Salicylates, like aspirin, are mentioned as drugs that can sometimes cause this.
Contributing to their erratic absorption patterns.
Potentially, yes. Another way absorption can be unpredictable.
Okay, so absorption is clearly complex in overdose. What about D-distribution? Once it's in the blood, where does it go, and how does overdose change that?
A key factor here is protein binding. Many drugs bind to proteins in the blood plasma.
And it's the unbound drug that's active.
Right. Generally, yes. The unbound fraction is what can exert pharmacological effects and get eliminated. In an overdose, you can have so much drug that you saturate all the available binding sites on those plasma proteins.
All the seats are taken.
Right, so a larger proportion of the total drug in the blood is now unbound, free, and active.
Which means more intense effects, more toxicity, even if the total concentration hasn't proportionally increased as much.
Exactly. Higher free fraction equals enhanced toxicity.
And body pH can affect this too.
Yes. Our source gives the example of tricyclic antidepressants. They become less bound to protein when the plasma gets more acidic.
So if an overdose patient becomes acidotic,
their free fraction of tricyclics increases, potentially worsening the toxicity. It's a nasty feedback loop.
And what about volume of distribution?
Drugs with a large volume of distribution spread out widely into the body tissues. They don't just stay in the blood. Meaning it's harder to remove them with treatments like hemodialysis, because only a small fraction of the total drug in the body is actually circulating in the blood at any given time. Most of it is hiding out in the tissues. Makes sense.
Harder to filter out if it's not in the filterable fluid. Okay, on to M&E, metabolism and elimination in overdose.
Crucial processes, and they can change dramatically under toxic conditions.
The big change is kinetic shifting, right? From first order to zero order.
That's a fundamental concept. Normally, many drugs follow first-order kinetics. A constant fraction or percentage of the drug is eliminated per unit time. Double the dose, double the rate of elimination initially.
But in overdose,
the enzymes or transport systems responsible for metabolism and elimination can get saturated, overwhelmed.
Like the formaldehyde example earlier.
Exactly. When the system is saturated, it can only work at its maximum rate, regardless of how much more drug is present. That's zero-order kinetics.
So a fixed amount is eliminated per unit time, not a fixed fraction.
Right. Ethanol is the classic example. At social drinking levels, alcohol dehydrogenase is saturated. Your body clears maybe 7-10 grams of alcohol per hour, period. Doesn't matter if you drink way more, the elimination rate stays roughly constant.
Which is why it takes so long to sober up after heavy drinking.
Precisely. And this isn't just ethanol. Phenytoin, the anti-seizure drug, is another key clinical example.
How does it work with phenytoin?
At therapeutic doses, it's metabolized mainly by CYP2C9 and 2C19, follows first-order kinetics, half-life around 20 hours. but push the levels into the toxic range,
Saturation.
saturation of those enzymes, it flips to zero-order kinetics, and the half-life can skyrocket. The source mentioned studies showing it can go over 100 hours.
Wow, so it just hangs around for days.
Yes. And adding complexity, those enzymes, 2C9 and 2C19, have genetic variations, polymorphisms, that affect their activity. So metabolism can vary a lot between people anyway, and saturation just compounds that unpredictability in overdose.
Okay, so slower elimination is one consequence of saturation. What else? Shunting to other pathways.
Yes, and this can be really dangerous. If the main metabolic pathway is saturated, the drug might be forced down alternative routes.
Yeah.
And sometimes, those alternative pathways produce toxic metabolites.
Acetaminophen again?
Acetaminophen is the poster child for this. Figure 9-4 illustrates it perfectly.
Remind us how that works.
Normally, most acetaminophen is safely conjugated, glucuronidation, sulfation, and excreted. A tiny bit goes down the CYP2E1 pathway to form NAPQI, a reactive metabolite.
But usually not a problem.
Usually not, because we have glutathione in the liver that quickly neutralizes NAPQI.
Okay. But in overdose.
The main conjugation pathways get saturated. More acetaminophen gets forced down that CYP2E1 route, producing much more NAPQI.
And the glutathione.
It gets used up trying to neutralize the NAPQI surge. Once glutathione runs out, the excess NAPQI starts damaging liver cells.
Leading to hepatotoxicity.
Exactly. And things that increase CYP2E1 activity, like chronic alcohol use or the drug isoniazid, can make this worse, increasing NAPQI formation even at lower acetaminophen doses.
A deadly combination of saturated safe pathways and depleted defenses.
Precisely. It's a critical mechanism to understand.
And sometimes it's not just about toxic metabolites from alternative pathways, right? Sometimes the normal metabolites are the problem.
Correct. Sometimes a metabolite produced through a standard pathway is actually more potent or more toxic than the parent drug. Tramadol is a good example.
How so?
Tramadol itself is an SNRI and a weak opioid agonist, but it's a metabolite, M1, O-desmethyl tramadol, made by CYP2D6, is a much stronger opioid agonist, hundreds of times more potent, apparently.
But it loses the SNRI activity.
Right. So metabolism changes both the potency and the overall pharmacological profile. And again, CYP2D6 is highly polymorphic.
Meaning people metabolize tramadol differently.
Very differently. Ultra-rapid metabolizers make a lot more of that potent M1 metabolite, increasing their risk of opioid side effects even at normal doses.
Wow. So genetics plays a huge role there too.
Absolutely.
Yeah.
And in other cases, a metabolite might not be more potent, but it might just have a much longer half-life than the parent drug, leading to prolonged toxicity.
Okay. We also need to talk about membrane transporters in elimination.
Yes, crucial role. These proteins actively pump drugs and metabolites across membranes in the liver, kidneys, gut, even the brain. They're key for getting drugs into organs for metabolism and out for excretion.
And drug interactions can happen here.
Definitely. One drug can inhibit or induce a transporter that handles another drug.
So if drug A inhibits a transporter that normally removes drug B,
drug B levels can build up, potentially reaching toxic concentrations because its elimination is blocked. Or if an uptake transporter is inhibited, drug B might not get into the target tissue effectively.
Table into 3 lists examples.
Yes, it lists substrates and inhibitors for important transporters, the ones the FDA often looks at in drug interaction studies. Appendix 2 and Chapter 4 have more detail too.
And Box 9-1 has that striking loperamide example.
Right, loperamide, the antidiarrheal, it's an opioid, but normally doesn't cause central effects because P-glycoprotein, PGP, in the blood-brain barrier pumps it out.
But if you take huge doses or take it with a PGP inhibitor,
it overwhelms or bypasses that pump, gets into the brain, and you can get serious opioid effects, even cardiac toxicity. Shows how critical these transporters are as gatekeepers. Figure 4.3 summarizes these transporter interaction mechanisms well.
Very clear danger there. Okay, we touched on protein binding interactions earlier.
Yes, competition for binding sites, increasing free drug levels, especially relevant in overdose, or with highly bound drugs like warfarin, phenytoin, valproic acid.
And metabolic interactions, like the acetaminophen ethanol example.
Right, where acute alcohol might protect slightly by competing for CYP2E1, but chronic use induces CYP2E1 and depletes glutathione, increasing risk. Very complex.
And interactions affecting elimination lithium was the key example there.
Yes. Lithium relies on kidney excretion. Drugs that reduce kidney function or affect how the kidney handles lithium can cause levels to rise dangerously.
Like NSAIDs.
Exactly. NSAIDs, like ibuprofen, can reduce renal blood flow by inhibiting prostaglandins, which decreases lithium clearance. Easy to get into toxic levels if you're not careful combining those.
Really highlights the need for awareness, even with common OTC drugs. Okay, we've covered how the body handles toxins. Now let's categorize the types of toxicity.
Our source starts with a useful distinction: side effects versus toxic effects.
What's the difference?
Side effects are usually undesirable effects at normal therapeutic doses, often predictable, maybe annoying, but not always needing you to stop the drug. Toxic effects, or drug toxicity, usually implies harm from supertherapeutic levels, overdose, accumulation, interaction, and often requires intervention, though the terms are sometimes used interchangeably.
Got it. And the source breaks toxicity mechanisms into 5 main types.
Yes. On-target, off-target, biological activation, hypersensitivity, and idiosyncratic.
Let's break those down. On-target toxicity.
This is when the toxicity comes from the drug interacting with its intended pharmacological target, but just too much.
An exaggeration of the desired effect.
Often, yes. It's usually dose-dependent. Barbiturates are the classic example. Therapeutic dose hits GABA-A receptors, causes sedation. Overdose hits the same receptors much harder, causes profound CNS depression, coma, death.
Same target, just way too much effect.
Right. And it's not always tissue-specific. Mifedipine, the calcium channel blocker.
For blood pressure.
Right. Targets calcium channels in blood vessels at normal doses. But in overdose, it can hit the same type of calcium channels in the heart muscle too strongly, causing dangerous hypotension. Still the intended channel type, just in the wrong place or too much effect.
Okay, so that's on target. What about off target?
This is when the drug binds to unintended molecular targets, things it wasn't designed to interact with.
Leading to unexpected effects.
Exactly. These often get picked up in preclinical testing or sometimes later in clinical trials or even after marketing. Terfenadine is the cautionary tale here.
The old antihistamine.
Yes, it was a prodrug, needed CYP3A4 to become active fexofenadine. But the parent drug, tafenadine, especially if levels got high due to dose or interaction.
What did it do off target?
It blocked HERG potassium channels in the heart muscle.
Not its intended antihistamine target at all.
Not at all. Blocking HERG channels leads to QTC prolongation on the ECG and potentially fatal arrhythmias like Torsades de Pointe.
Which is why it was pulled from the market.
Correct. A serious off-target effect discovered mainly through post-marketing surveillance and reports of interactions. It shows how crucial that ongoing monitoring is. Many drug withdrawals have been due to off-target effects or interactions cropping up later.
A really important safety net. Okay, third type. Biological activation.
We've covered this concept already, actually. It's when the parent drug isn't the main problem, but it gets metabolized into something toxic.
Acetaminophen to NAPQI again.
Exactly. Acetaminophen itself is relatively safe, but its metabolite NAPQI, formed via CYP2E1, is the culprit causing liver damage when glutathione is depleted.
So the body activating the toxin?
Precisely. And many carcinogens work this way too, including some cancer drugs. They need metabolic activation to become DNA-damaging agents.
Okay, fourth type. Hypersensitivity reactions. These are immune-related, right?
Yes, essentially allergic reactions. The immune system overreacts to the drug, usually after prior sensitization. Chapter 38 goes deep into the immunology, but our source outlines the 4 main types.
Type I, anaphylactic.
Yes, IgE-mediated. Think classic allergies. Prior exposure leads to IgE antibodies on mast cells. Re-exposure causes the drug to cross-link the IgE, triggering mast cell degranulation release of histamine, leukotrienes, etc.
Causing
Vasodilation, leaky capillaries, edema, inflammation. Symptoms can be hives, asthma, GI upset, or worst case, anaphylactic shock. Very rapid onset, immediate hypersensitivity.
But sometimes reactions look like anaphylaxis without IgE.
Yes, that's an important point mentioned. Some drugs can directly trigger mast cells via a receptor called MRGPRX2, bypassing the need for IgE or prior sensitization. Leads to anaphylactoid reactions, look similar, different mechanism. Clinically worrying because it can happen on first exposure.
Okay. Type 2, cytolytic.
IgG or IgM antibodies target antigens on cell surfaces, often blood cells. Antibody binding activates complement, which destroys the cells.
Like drug-induced anemia or low platelets.
Exactly. Penicillin-induced hemolytic anemia, quinidine causing thrombocytopenia, usually stops when the drug is stopped.
Type 3, Arthus reaction.
This involves antigen-antibody complexes, mainly IgG. These complexes form in the blood, deposit in small blood vessel walls, skin, joints, kidneys, and trigger complement activation and inflammation there.
Causing serum sickness symptoms, rash, joint pain, fever.
Yes, often seen with antibiotics. It takes days to develop, resolves after the drug clears.
And type 4, delayed type.
This one is cell-mediated, involving T lymphocytes, not antibodies. Sensitized T cells encounter the drug antigen again, release cytokines, attract macrophages, causing inflammation.
Like poison ivy rash.
Exactly. Takes 2-3 days to appear. Allergic contact dermatitis is a classic type IV reaction.
Okay, that covers the 4 immune types. Last category, idiosyncratic reactions. The weird ones.
Pretty much. These are abnormal reactions unique to an individual, rare, unpredictable from preclinical studies, often don't follow clear dose-response rules.
Misunderstood.
By far. Thought to involve complex immune responses in people with specific genetic predispositions, really an interaction between the drug, the patient's unique immune system, and their genetics.
Examples.
Severe skin reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis are often idiosyncratic. Also, many cases of drug-induced liver injury, the non-acetaminophen kind, really tough to predict or prevent.
Okay, that gives us a good map of the types of toxicity. Now, drug interactions, a huge practical issue.
Huge. So many people are on multiple meds now, prescriptions, OTCs, supplements. The potential for interactions is massive.
And the 2 main mechanisms are pharmacokinetic and pharmacodynamic. Figure 9-5 summarizes this.
Right. Pharmacokinetic is when one drug changes the ADME of another. Pharmacodynamic is when their effects interact at the target site or pathway. Both can lead to treatment failure or unexpected toxicity.
Let's quickly revisit pharmacokinetic interactions. We've covered many examples. Absorption changes.
Yep, like changing GIPH, ranitidine increasing triazolam absorption, or binding in the gut, calcium antacids reducing levothyroxine absorption.
And transporter involvement.
Crucial. PGP, OATs, BCRP, etc. Inhibiting efflux transporters like PGP increases absorption. Verapamil boosting dabicran. Table 9.3 of Box 9-1, Figure 4.3 are key references here.
Protein binding competition.
Yes, displacing another drug, transiently increasing its free level.
Metabolic interactions.
One drug inducing or inhibiting the enzymes, especially CYPs, and metabolize another. The complex acetaminophen ethanol interaction fits here.
And elimination interactions.
Like the lithium examples, NSAIDs, diuretics reducing its renal clearance. Always one drug messes with the concentration of another.
Okay, so that's pharmacokinetic. What about pharmacodynamic interactions? No change in concentration here.
Correct. It's about the combined effects. 2 drugs acting on the same receptor or having similar or opposing physiological effects.
Maybe good or bad?
Can be desirable additive effects, like using multiple antihypertensives, beta blockers, ACE inhibitor, diuretic, that work differently but add up to lower blood pressure.
And undesirable.
Definitely. The classic dangerous one is combining nitrates, which increase CGMP, with PDE5 inhibitors like sildenafil, which blocks CGMP breakdown.
Too much vasodilation.
Catastrophic vasodilation and hypotension, a direct pharmacodynamic interaction with severe consequences.
Got it. Effects adding up or opposing each other. Okay, shifting gears. How do we even start to assess toxicity before drugs reach humans? Preclinical testing.
There are 2 main assumptions underlying animal toxicity testing, according to our source.
Assumption 1.
That effects in lab animals, if done properly, predict human toxicity. And generally, toxic effects happen in a similar concentration range if you adjust for body surface area. Though humans might be more vulnerable based just on body weight sometimes.
Okay. Assumption 2.
The testing at high doses in animals is a valid way to find hazards that might occur at much lower doses in humans. This goes back to the quantal dose response idea.
But there's a problem with scale.
Huge problem. You test maybe dozens or hundreds of animals, but millions of people might eventually take the drug.
So how do you find rare side effects?
You probably can't directly in standard animal studies. If a serious effect happens in, say, 1 in 10,000 people, you'd need an enormous animal study to reliably detect it. That's why they use high doses in smaller groups.
To increase the chances of seeing some kind of toxicity.
Right. To maximize the chance of uncovering potential hazards, assuming that effects seen at high doses might indicate risk, albeit lower at lower doses.
But extrapolating that high-dose animal data to low-dose human risk is tricky.
Very tricky. It's a central challenge in toxicology and risk assessment. Chapters 1 and 8 delve deeper into these issues.
Okay, so that's preclinical. Now, in the real world, how do we track poisoning incidents? Epidemiology.
We need multiple data sources. Death certificates, hospital discharge data give you the severe end.
But miss less severe cases.
Right. That's where the U.S. Poison Control Centers, PCCs, come in. There are 55 regional centers.
And they collect data.
Yes, they handle over 2 million reported human exposure cases a year. It's voluntary reporting, so it may be biased towards less severe cases where people call for advice, but it's a massive repository of data.
What does this data show? demographics?
The 2019 report cited shows about 643 exposures per 100,000 people. Kids under 6 have the most reports, probably exploratory ingestions.
But highest rate is adults.
Adults 2039 have the highest exposure rate per capita. Table 94 shows the scenarios. Unintentional dominates in young kids, intentional exposures, self-poisoning, rising in teens, and adults are mostly intentional or adverse reactions.
What substances are involved?
Table 95 breaks it down by age. Different patterns for kids versus adults, as you'd expect. Cosmetics, personal care products are high for young kids. Analgesics are high for adults.
And the really sobering statistic.
Drug poisoning, unintentional and intentional, was the leading cause of injury death in the U.S. in 2019. Over 70,000 deaths.
Driven largely by opioids.
Yes, opioids involved in over 70% of those overdose deaths in 2019. A huge public health crisis.
But most PCC calls don't end in fatality.
Thankfully, no. Only about 0.12% of reported cases in 2019 were fatal. Table 96 shows the substances most commonly linked to those fatalities reported to PCCs, sedatives, hypnotics, opioids, cardiovascular drugs often top the list.
Okay, given these numbers, prevention is obviously key. How do we prevent poisonings? Starting at home.
Both primary prevention, stopping it from happening, and secondary prevention, reducing harm if it does happen. Table 97 outlines strategies.
And we've made progress.
Huge progress in childhood poisoning over decades. Better safety packaging, public awareness, it really works.
Primary example.
Making products less toxic, like taking ethanol out of mouthwash, limiting package sizes, and crucially, child-resistant packaging and safe storage, keeping things locked up out of reach.
Secondary prevention.
Making sure people know help is available. Promoting the Poison Help Hotline. 1-800-222-1222. Quick access to expert advice.
Okay, what about prevention in healthcare? Medication errors.
Big focus now on reducing errors and adverse drug events. A medication error is any preventable event that could lead to harm. They happen more often than actual adverse events.
How do we reduce them?
It needs a systems approach, looking at every step. Prescribing, transcribing, dispensing, administering, monitoring. Training is vital, but also building in redundancies, checklists, forcing functions.
Table 9 to 8 lists strategies.
Yes, lots of practical things hospitals and clinics can do, from how they select and store drugs, to order entry systems, to double checks during preparation and administration, to patient education to discharge. It's about making the system safer, not just relying on individuals to be perfect. Chapter 8 discusses post-marketing surveillance aspects, too.
Makes sense, focus on the system. But despite prevention, poisonings happen. How are they managed clinically?
Most calls to PCCs are managed at home, but many do need medical care. PCCs are crucial resources for docs, too, 24/7 expert advice.
And the approach in the ER, figure 9 to 6, gives steps.
Yes, stabilization first, then clinical evaluation, then treatment, often happening simultaneously.
Stabilization is ABCs.
Always. Airway, breathing, circulation, top priority. Box 9 to 2 outlines it. May need intubation, ventilation, fluids, pressors in severe cases. Maintain vital functions above all else.
Then evaluation. Toxidromes.
Yes, recognizing patterns of signs and symptoms linked to specific poison classes. Table 99 has examples: vital signs, pupil size, skin, mental status. These clues can point towards, say, an opioid or anticholinergic overdose.
Guiding initial treatment.
Exactly. Though patients might not show the full classic picture, especially with multiple drugs, physical findings can be the only clues initially.
What about lab tests?
Hospitals can usually run quick tests for common things like acetaminophen, salicylates. Urotox screens for drugs of abuse are fast but have limitations: false positives, negatives, long detection times. Need to be interpreted carefully. Other specific drug levels might take longer.
ECG is useful.
Very. Table 910 highlights this. Looking for QRS widening, like with tricyclics blocking sodium channels, or QTC prolongation, like with drugs blocking HERG potassium channels, can indicate specific toxicities and guide therapy.
Okay, stabilization and evaluation happen alongside treatment. What are the main treatment pillars?
Supportive care is number 1. 4-IV fluids, anti-nausea meds, benzodiazepines for agitation or seizures. Managing the symptoms?
The more specific things.
Yes. Decontamination, enhanced elimination, and antidotes.
Let's tackle decontamination first. Goal is to stop more absorption.
Right. Depends on the road. Table 911. Skyneys get washed. Inhalation means move to fresh air. Ingestion is most common.
And for ingestion, it's mainly activated charcoal or whole bowel irrigation now.
Pretty much. Gastric emptying, lavage, ipecac, and cathartics alone are rarely used anymore.
Why charcoal?
Huge surface area, absorbs many toxins via weak bonds, trapping them in the gut. Dose is typically weight-based, up to 75-100 grams.
Doesn't work for everything.
No. Poorly absorbs alcohols, corrosives, hydrocarbons, metals like iron or lithium. Can cause nausea, vomiting, constipation. Aspirations are the big fear, so need a protected airway if consciousness is low. Its use is declining overall.
Whole bowel irrigation, WBI. Sounds intense.
It is. Flushing the entire GI tract with large volumes of polyethylene glycol solution. Like prepping for a colonoscopy, but faster.
What is it used? Table 912.
For things charcoal doesn't bind well, like iron. Sustained release pills, body packers smuggling drugs, ingested patches, things you want to physically push out quickly.
Downsides.
Nausea, vomiting, aspiration risk. Can't use it if there's bowel obstruction or perforation or uncontrolled vomiting.
And gastric emptying lavage and Ipecac, why are they out of favor?
Studies showed they remove surprisingly little drug, maybe only a third at best, even when done early. Plus risks trauma from lavage tubes, aspiration, Ipecac causing prolonged vomiting that prevents other treatments like charcoal or antidotes. AAP and ACP advised against Ipecac now. Very rare use.
So decontamination is mainly charcoal or WBI in select cases. What about enhancing elimination of what's already absorbed?
Several techniques. Manipulating urine pH is one.
Making urine alkaline to trap weak acids.
Right, ion trapping. Increases ionization of drugs like salicylates or phenobarbital. Preventing reabsorption in the kidney tubules, enhancing excretion. Usually done with a sodium bicarbonate infusion.
Only for specific drugs.
Yes, and typically only for moderate salicylate toxicity if dialysis isn't needed. Acidifying urine for weak bases isn't recommended due to risks.
Multiple dose activated charcoal, MDAC.
Giving charcoal repeatedly works by interrupting enterohepatic cycling binding drug excreted in bile. Also creates a gut dialysis effect. Drug diffuses from blood into the gut lumen, down a concentration gradient maintained by the charcoal. Table 913 lists drugs where MDAC helps.
And extracorporeal removal.
Dialysis.
Hemodialysis, mainly. Reserved for severe, life-threatening poisonings not responding to other measures or when kidneys fail.
What makes the drug dialyzable?
Needs to be small molecule, low volume of distribution, stays in blood, water-soluble, not highly protein-bound. Used for things like toxic alcohols, methanol, ethylene glycol, lithium, salicylates, metformin, valproate, carbamazepine when severe. Okay, the heavy artillery. Finally, antidotes, specific counteragents.
Yes, crucial in many poisonings. They work in different ways.
Chemical antidotes.
Bind directly to the toxin to inactivate it. Digoxin immune fab for digoxin antivenoms, chelators like deferoxamine for iron, sugametics for certain muscle relaxants.
Pharmacological antidotes.
Compete with the toxin at the receptor. Naloxone-bumping opioids off receptors is the prime example.
Physiological or functional antidotes.
Counteract the poison's effect via a different mechanism. Glucagon for beta blocker overdose works by boosting KMP in the heart, bypassing the blocked beta receptors.
Dispositional antidotes.
Affect the toxin's metabolism or handling. Fombazole stops alcohol dehydrogenase from making toxic metabolites from methanoethylene glycol. L-carnitine helps detoxify valproic acid via beta oxidation.
Table 914 lists many common ones.
Yes, a great resource showing specific antidotes and their uses.
It's amazing the range of specific treatments available. Given all this complexity, where can people find reliable info?
Lots of places. Authoritative tox textbooks, drug databases with tox sections like Poisindex or LexiTox, the National Library of Medicine's PubChem, the Consumer Product Information Database, CDC's ATSDR for environmental toxins, the EKSD Workgroup for dialysis recommendations.
Poison Control Center.
Absolutely. Always emphasize the 1-800-222-1222 number, available 24/7 for expert advice for public and professionals. Invaluable resource.
This has been incredibly thorough. We've really gone deep into clinical toxicology, dose response, toxicokinetics, types of toxicity, interactions, testing, epidemiology, prevention, management, resources. It's so clear how complex it is, dose, physiology, interactions, all playing a part.
It truly is. Understanding these principles is vital for healthcare pros to keep patients safe, but also useful for everyone to understand medication risks and prevention.
Absolutely. And it makes you think, doesn't it? Despite all this knowledge, predicting and preventing all adverse drug events remains a huge challenge. You wonder, with pharmacogenomics advancing, how close are we to truly personalized toxicology, being able to know in advance who's likely to react badly to a specific drug based on their genes?
That's the dream, isn't it? A future where we can tailor therapy much more precisely to minimize harm. It's a field that's constantly evolving, constantly learning.
Definitely food for thought. If you want to explore more, check out those resources we mentioned, or remember that Poison Help Hotline is always there for questions.